Hi guys, good day. I hope we're all good. My name is Daniel Guinness and I'm currently a fifth year medical student at the University of Lagos. I just completed my fourth year, which is the first clinical year for me, and this fifth year is the second clinical year for me. All right, we are here majorly to discuss history taking in medicine and in surgery. The major reason why I'm doing this video is because I want people who are about to enter into their clinical years to have like a first point of contact before they eventually start clinical school. And all these things that I'm going to mention will be reiterated for you, and you will be taught all of these things across the clinical postings in your fourth year. All right, and this kind of forms like a really, really good background for you to click very well, take history, amongst other things that you need to do in your clinical school. All right, so let's dive straight into it. So what is history taking? It's in the name, history taking. It's basically you taking history from a patient, from someone who has come to meet a doctor, right? Which is you in this case. Good. So what you want to do is you want to try your best to source out information from the patient, because you are going to be asking questions. You need to ask the patient questions about themselves, about why they are here, about their family, about whatever problems they are facing, all right? And the hope is that along the way, you know exactly what is wrong with the patient and you probably can find a solution to it, right? So history taking is not just done anyhow. It has to be done in a very systematic manner, in a logical manner, in an organized fashion, and it must be thorough, all right? This is very, very crucial in the diagnosis of the patient's problem. Why? Because it is said that most of the answers to a patient's problem lies in the history. So once you can take a very, very good history, you're already on the way to solving a patient's problem. So you have to make sure that your history taking is thorough, logical, and organized. And that's exactly why we're here, so that you have a systematic manner, a systematic approach to asking patients questions, so that you'll be able to diagnose them and find solutions to their problem. The remaining 10% of finding solutions to a patient's problem lies in the physical examination that you do and in the investigations that you eventually carry out. And that will be talked about in a different video. But the major purpose of this video is history taking. Okay, so now that we know a bit, at least we have an idea about what history taking is, how do you take history? So if a patient comes to the hospital and sits in front of you, what do you do? So basically, history taking, or you taking history from the patient, is going to entail you writing down some things on a paper. That paper, we call it a clerking sheet. All right, so you'll be given a clerking sheet as a student that you are. Of course, you should have your biro, your pen with you. You're going to use to write down some of the things that you ask the patient and the patient responds back to you. What you want to do is you want to try to make sure that you don't lose your patient, in the sense that you communicate very, very well, all right? Try to maintain some eye-to-eye contact sometimes, all right? Try to not spend too much time writing, because that's one thing that medical students do, that we do once in a while. We can get lost in our writing down. As you're asking the patient the questions, take some time to listen. Oh, okay, no problem, thanks for that. And then you write something down. You don't want to spend too much of your time, your eye fixated on your book. You don't want to do that. You want to try to maintain some eye-to-eye contact with your patient, so that they feel very comfortable with you and they can even tell you more things that are very, very important for your diagnosis. All right. So you have your paper with you. Okay. The first thing I do is, when I have my patient in front of me and when I have my clerking sheet with me, what I do is, I first of all, on the paper, you take note of the dates and the time, so that you know when you're starting your history taking. The next thing you want to do is greet your patient. You want to create rapport with your patient. All right. So one thing you have to do as a doctor, one thing that a doctor has to have, is empathy. You are not just coming to the hospital and then you're like, oh, madam, what do you want? Okay, no, you're not doing that. What you're trying to do is you're trying to make your patient comfortable, because you don't know if your patient has come from a really, really far place. You don't know if your patient is in so much distress. Sometimes your patient can be irritable. So what you want to do is that you want to calm down. You want to also create a warm environment for your patient. So the next step, I've talked about history taking and what it means. All right. The first thing that you want to do when you want to begin your history taking is that you want to greet your patient and create rapport with your patient. How do you do this? So you have a patient in front of you, and then you've written your date and your time on your clicking sheet. And then you look at your patient. Good afternoon, ma. How are you doing today? I really hope it wasn't so stressful coming to the hospital today. I hope you are fine. It shows that you care about the patient. It makes the patient feel a little bit at ease. All right. So that right there is you creating rapport with your patient. There's a particular mnemonic that we use in some schools, at least in my school here as well. GITE. You can say GITE or GITE. So G is you're greeting your patient. All right. You greet your examiner and your patient. It depends. So if you are in your clinic or if you are in ward round or whatever the case might be, and you don't have anyone supervising you, of course you greet only the patient. But if you are in a place where your examiner is there, of course you have to greet your examiner first before you greet your patient. So G is greet your examiner and patient. I is introduce yourself. T is you want to take consent. And your E is you want to establish rapport. So this is the first step in history taking. GITE, you can call it GITE or whatever the case might be. All right, so that's GITE. You want to greet your patient, you want to introduce yourself, you want to take consent, and all through this introductory period, you are establishing rapport. So imagine I have a consultant with me, all right? You greet, good afternoon, ma. Good afternoon, sir. Assuming the ma is the consultant and the patient is a sir. Good afternoon, ma. Good afternoon, sir. So I really, really hope getting here wasn't too stressful, and I hope you are fine. I hope you are doing well today. My name is Doing Goodness, and I'm currently a fifth-year medical student. My consultant has assigned me to take a detailed history from you regarding your condition. This will entail me asking you some questions. So now, let me take a pause. What am I doing? I'm using that GITE, right? I've greeted my patient. I've introduced myself. That's where I say, good afternoon, sir. Good afternoon, ma. My name is Doing Goodness. I'm currently a fifth-year medical student. That is you introducing yourself. After introducing yourself, what you want to do is you want to tell the patient why you are here. What are you doing? So now let me give my introduction. All right. I'm assuming my examiner is here. Good afternoon, sir. Good afternoon, ma. My name is Doing Goodness, and I'm currently a fifth-year medical student. I have been assigned by my consultant to take a detailed history regarding your condition, regarding why you are here today. This will entail me asking you a series of questions, and I would love you to be as accurate as possible, as this would allow us to understand the condition better, and it will also help me in my assessment. Please, can I go ahead, ma? Oh, thank you so much. So this is all about the introduction. I've gone through my GITE, my greeting and creating rapport. Remember, I greeted my examiner, I greeted the patient, I introduced myself, I said why I was there and the purpose of me taking the history. I took consent. So these are the things that you have to do as you start your history taking. Try to make your patient very, very comfortable. And then after this, we'll go into the next part, which is the biodata. All right, so moving on to the biodata. So we've greeted our patient, we've created rapport with our patient is comfortable in front of us. All right, and remember you have your clicking sheet with you. You've written out your dates and your time. Okay, so the next thing you want to do is to collect the biodata. So just like the name implies, biodata, you're literally collecting information about the demographic of the patient. Okay, you're asking for their name, their age, where they are from, all right, all those things. But remember, everything is done in a systematic manner, all right? So the next thing you want to write on your clicking sheet is you want to write biodata. and then you're taking the biodata of the patient down. And then you're asking the patient and writing it down at the same time. So for this biodata, there's a particular mnemonic that we use everywhere. There's some modifications to the mnemonic though, but the one I stick with is Nasarom TIL. So NASAROM TIL. Nasarom TIL. Now, something I love about medicine is that for everything that you do, for every question you ask in bone medicine and in surgery, there's a reason for it. We just don't ask questions anyhow. There's a reason why we're asking questions. There's a reason why we're taking your name. There's a reason why we're asking for your age. Do you understand? So behind every question you ask your patient, there is a reason for it. All right, so the biodata is going to contain Nasarom TIL. So what we usually do is we just write NASAROM TIL. All right, so Nasarom TIL. So I'll tell you what this means and why we're asking some of them. So the N is the name. You want to ask for the name of the patient. The A is the age. S is sex of the patient. The other A is address of the patient. R is religion. O is occupation. M is marital status. T is the tribe. L is the level of education of the patient. And I is informant. I'll go through what each of these means. Remember that this is biodata. All right. So the mnemonic, like we said, is Nasarom TIL. And let's look at why we're collecting some of these things now. Okay, so of course you want to ask for the name of your patient. Let's say their name is what can I use? Binta Adeleke. Binta Adeleke. Let's say that is the name of the patient. All right. She tells you her name. You ask for the age. You ask for the sex, and so on and so forth. Now, as a current say, ma, your name, your age, what's your sex, address, religion, occupation? No. Remember that this is a human, conversing with someone. So you are saying, please, ma'am, may I know your name? Oh, all right. And please, how old are you? Of course, you can see the sex. So you don't have to ask, ma, what's your sex? We don't usually do that. All right. Then you ask, oh, please, where do you live? Or what's your address? Oh, ma, please, can I know what religion you practice and what church you attend, if they are Christians? Do you understand? So you are asking questions, you are sourcing out information from them. You are asking these questions, you know how it's going to be arranged in your book, but you're not doing it in a textbook way. You're not saying your name, man, your age, man, your address, man, your marital status, man, your this, man. No. You're conversing with someone. So try to make sure the communication is flowing. All right. So now you ask for the name. Ma, please, can I know your name? She tells you her name. You write it down. Okay. You ask for the age. Now, why are you asking for the age? You're asking for the age because remember, some diseases are associated with age. They are age specific. There are some diseases that are more prevalent among the old. There are some that are more prevalent among the young. So the age is quite important. Very, very important. Imagine someone who has a lump in their breast, all right, and she's in her mid-20s, all right, or early 30s. You're thinking of something like a fibroadenoma. Do you understand? So the age is very, very specific. It's very, very important. Very, very important because there are some diseases that are associated with age. All right. If you see someone with prostatic cancer or colon cancer or BPH, benign prostatic hyperplasia, they are associated with age, usually most of the time. So age is very, very important. The sex, of course, is also very important because you know as well that there are some diseases that are associated more with females than males, and some males than females. So the sex is important. Moving on to the address. So now this address is quite important as well. You're asking the patient, please ma or please sir, where do you live? Where do you stay? So there are some, for example, if someone has cholera, the address might be important. If someone has a viral hemorrhagic fever, the address might also be important. You want to know, where do you live? Where do you stay? Is that place a breeding site for some diseases? All right. So the address is quite important. It's very, very important. That's not the only reason. There are so many other reasons, so many other school of thought. All right. But this is what I think the address is for. Because remember, for everything in medicine and surgery, there is a reason we're asking each question. So the address can be important for several reasons, but one of the reasons is also because you want to know where the patient is coming from. All right. Okay. The religion are super, super, super important. I cannot overemphasize this. Very important in the sense that you ask the patient, please, ma, can I know what religion you practice? And they say, oh, Christianity. Oh, that's good. So in your paper, you're writing Christianity, but you just don't stop there. You go further to ask, what denomination are they? All right? Because you want to know if, for example, they are Jehovah Witness. Jehovah Witness, they do not participate in blood transfusion. All right? So you have to know. This is why the religion is quite important. If they are Muslim, you write it down. It has to be in the religion. You also want to know the occupation of the patient. That's O, Nasarum. O, you want to know the occupation of the patient because you also know that there are some diseases that are associated with some occupation. You know that. All right. You know that from our preclinical knowledge. There are some diseases that are associated with occupation. If they say that they are students, if that's the occupation, you want to know what school. So you write student and you put in bracket the name of the school. If they are traders, you want to know what do you trade. Do you understand? So you're not just writing a trader. What does she sell? What does this person sell? So trader in brackets sells books or does this, does that. All right. Then the marital status M is also very, very important. You want to know if this person has someone to go back to at home. That can be a reason as well. If they have emotional support, all right, that is very, very key. So marital status is also very, very important. That's the M. The tribe, T. Tribe is super, super important. You want to know if they're Yoruba, if they're Igbo, all right. Then I'll go back to I. L, the level of education. We all know that level of education is important. It plays a role in the conversation that you're having with the patient, and it tells more things, all right. So level of education is important. If the person is an SSC holder, you write it there. If it's OND, HND, write it there. If the person is a BSc holder, write it there. PhD holder, write it there. It is very key as well. Then the I, informant. Now, who is an informant? An informant is someone who tells you the history, who is not the patient. Someone who is not the patient telling you the history. So imagine a person comes into the emergency department and is unconscious, but has his mom with him. It is not the unconscious patient that is going to talk to you. It is the mother. So at the informant place, you're going to write mother, right? And usually we say that the informant's information is reliable when they are close relatives, all right? When they are close relatives or when they were at the site of what happened. Does that make sense? So that's from TIL. Before I forget, there are so many reasons why you would need an informant. For example, if the person is a child, as you see in pediatrics later on, if the person is a child, you need an informant. A young person who cannot really articulate some information to you, you need an informant. You would put the informant there. If the person is unconscious, like I mentioned earlier, and probably the person cannot communicate for one thing, for one reason or the other. Probably they have aphasia. They might not be able to communicate well to you. You have to mention the informant. Okay? So I said the biodata is all about what? Nasarum TIL. Name, age, let's say it together. Name, age, sex, address, religion, occupation, marital status, tribe, informant, and level of education. So that's that about the biodata. So now let's move to the next step, the next thing I'm going to write, which is presenting complaints. All right, so moving on to the next step after the biodata, which is the presenting complaint. Okay, so what is presenting complaints, right? Because, after you've written your biodata on your clerking sheet and you've gotten your Nasarum TIL, the next thing you're writing is PC. That's presenting complaint. Now, what is presenting complaint? Now, presenting complaint is the major reason or the main reason why the patient came to the hospital today. Now, I'm going to give you an example. Let's say a patient had malaria 3 years ago. She treated it, she was fine. But she came to the hospital today complaining of sore throats, headache, right? And she comes to me and she tells you, and you ask her, oh, Ma, please, why are you here today? And she tells you, oh, I have sore throats, I have headache, right? I had malaria some time ago. No. In your presenting complaints, you're not writing malaria. You're not writing what happened to the patient a long time ago. No. Why is the patient here today? Why are you here today, Ma? What is the problem? Why are you here today? So you're not writing, in your presenting complaints, you're not writing what happened to the patient 10 years ago and is not a problem today. If what happened to the patient 10 years ago is still occurring now, if it has been something that has been happening for a long time and it's still happening today, like it brought the patient to the hospital, then you write that. But in your presenting complaint, what you're looking at, what you're writing is the reason the patient is in the hospital that day. Why is the patient in front of you? That is what you're writing in your presenting complaint. Now, I've told you that the presenting complaint is the major reason why the patient came to the hospital. So you are asking the patient, please, Ma, please, sir, what brought you to the hospital today? All right? And we are usually advised that we should write the presenting complaint in the patient's own words. It should be written in the patient's own words. Now, this part can be tricky. Now, follow me. So a patient comes to the hospital and says they're presenting complaint. You ask their presenting complaint and they say that they have sore throat, all right? They have sore throat, they have pain in their back. Those are presenting complaints. So you're writing sore throat, number one, and number two, you're writing pain in the back. Now, if the patient comes to meet you and then the patient tells you, I have cervical pain, I have lumbar pain, or the patient tells you, I have lumbar fracture, or I have cervical fracture, or I have humeral fracture, you're not writing that in the presenting complaint. Now, sometimes patients use medical terminologies that they are not familiar with. All right, so you have to be very, very careful. You have to try to make sure that you write it in the patient's own words, yes, but you have to make sure the patient is also correct about what they are saying. So if the patient tells you they have lumbar pain, you're like, oh, Ma, where can you show me what do you mean by lumbar pain? You have pain in your lumbar spine. What do you mean by that? And the patient is touching the back. You can just write back pain in your presenting complaint. Does that make sense? If they say that they have fracture of something, all right, you are the one that will try to source out that basic information. That information they see must be recorded in patient's own words. Sometimes if the patient uses big words that are so somehow, you have to be the one to try to even break it down sometimes, all right? But most of the time, you see patients that just tell it to you direct. Oh, I have back pain, I have pain in my shoulder, I have chest pain, I have pain here, or I have, I'm finding it difficult to walk. These are things that you can write as your presenting complaint, all right? Or a patient says, I'm coughing, so cough is a presenting complaint. Or I feel breathless whenever I'm walking the stairs, or I feel I lose my breath easily, or I gasp for breath. Breathlessness is a presenting complaint. You can write that, right? So you have to be very, very careful. You have to be very, very careful with how you interact with patients when it comes to the presenting complaint. Now, still on this presenting complaint, you have to make sure that there are not too many. What do I mean? So if the patient is telling you, I have this, I have this, I have this, I have this, you have to try to make sure your presenting complaint is within 2 to 3 presenting complaints, because sometimes other complaints might be inside another particular complaint. Does that make sense? All right. So try to limit your presenting complaints average of 2 to 3. All right. Don't let it be more than 5. Do not let it be more than 5. Let it be a max of 5. But around 2 to 3 presenting complaints, that's good. That's good. And you have to make sure that the presenting complaint is written in a chronological order. What do I mean? It has to be from the first symptom that happened to the most recent symptom. Now let's give an example. A patient has complaints and you ask the patient, and the patient is telling you, I have cough, I have chest pain, I have fever. All right. Now, you're asking the patient, oh, which one started first? Which one did you notice first? Oh, I noticed the cough 2 weeks ago. Then 1 week ago, the fever came, and then chest pain started yesterday. So you have to write it, your presenting complaint PC has to be in the order of which one started first. All right. So if I say cough started 2 weeks ago, you're writing cough first. Which one came next? Oh, the fever was 1 week ago. That's the number 2. And then which one is the most recent? Oh, the chest pain. That's the number 3. So it must be in a chronological fashion, the one that came first to the most recent. And finally, on this presenting complaint, what I'm going to talk to you about is the duration. You have to ask the duration. So remember, the patient already said, cough started 2 weeks ago. So your number 1 was cough 2 weeks ago. So that's writing cough 2 weeks ago. Now there's a shorthand. There's a short form of writing 2 weeks ago, or a week ago, or a day ago, or this. I'm going to talk about that. But remember that I've told you the first thing I'm going to write is cough 2 weeks ago. The next thing is fever 1 week ago. The next thing is chest pain, let's say 4 days ago. All right. So now we do this thing whereby I write times 3/7, for example. Let me give that as an example. Times 3/7. 3/7. So with 7, you have 7 days in a week, right? So whenever you see 3/7, it means 3 days ago. If you see something like 3/52, you have 52 weeks in a year. So that is 3 weeks ago. If you see something like 1/12, 12, you have 12 months in a year. So that is what? 1 month ago. You have 12 months in a year, so that's 1 month ago. All right. So remember, if you see something over 7, that's talking about days. If you see something over 52, it's talking about weeks. If you see something over 12, it's talking about months. All right. So if I say that the patient had cough 2 weeks ago, what am I going to write? 2 weeks ago. Thank you. Cough times 2/52. Does that make sense? Cough times 2/52. If you see a patient says that I have back pain, it started 3 months ago, you're writing back pain times 3/12. That's 3 months ago. So those are short forms. If they say they had something 3 years ago, you're writing, let's say chest pain 3 years ago, you're writing chest pain times 3 years. Just write times 3 years. Right? So when you see something over 7, it is days. When you see something over 12, it is months. When you see something over 52, it is weeks. Okay, and that is basically that about the presenting complaint. So the next thing we're going to go into now is what we call history of presenting complaint. So let's see that quickly.